I'm very happy to be here back at Trivandrum, as it brings me back memories during my postgraduate days here. I bring greetings from Krishna Institute of Medical Sciences, which is one of the corporate hospitals in Hyderabad, where I head the fertility services. So hyperprolactinemia is the commonest endocrine disorder of the hypothalamic pituitary axis, and it is more commonly seen in women. If we look at an unselected adult population, the prevalence of hyperprolactinemia is about 0.4%. However, the prevalence is higher in women with reproductive disorders. So in women who present with adult onset amenorrhea, close to 10% or 1 in 10 women have hyperprolactinemia. And when we are going to look at a group of women who also have galactorrhea, this incidence goes up even higher. So hyperprolactinemia is a very common disorder in women who present with anovulatory infertility. Hyperprolactinemia is defined as a serum prolactin level above the normal range. However, it is very important to remember that once a high prolactin level is noted in the blood, it doesn't necessarily mean that we need to initiate treatment for hyperprolactinemia to bring it back to the normal level. We need to always treat the patient in conjunction with the lab value, and we are not trying to treat an abnormal lab value here. So the diagnosis of hyperprolactinemia is just the beginning and not the end of the process to initiate treatment. So once a high prolactin level is found, it is very important to do a confirmatory prolactin assay, and this repeat assay, in view of the circadian levels alteration of the prolactin levels, it's important to repeat this on a fasting level in a morning sample. And when the serum prolactin level is elevated on 2 separate occasions above the normal range for the laboratory, then this confirms the presence of hyperprolactinemia. Again, when hyperprolactinemia is confirmed, the next step in the diagnostic evaluation is to find out the causes of this high prolactin level. In general, they can be divided into physiological causes, pharmacological, and pathological causes. It is very, very important before we initiate treatment to bring down the prolactin level that we are going to look into the etiologies, as not all etiologies need treatment with dopamine agonists, and in some of the secondary causes which lead to hyperprolactinemia, what is needed is treatment of the secondary causes so that prolactin level reaches the normal level. So this diagram shows some of the common causes of hyperprolactinemia. But what I would like to focus here is prolactin is secreted by the lactotrope cells of the anterior pituitary, and this is under constant inhibitory influence of the dopamine which comes from the hypothalamus. So dopamine binds with the dopamine receptors in the lactotropes in the pituitary, and this constantly inhibits the prolactin secretion. So any condition which alters this regulatory process is likely to increase prolactin levels, leading to hyperprolactinemia. Some of the conditions which acts through dopamine or inhibiting dopamine, the most common of which are the drugs. Again, though there are a long list of drugs which can influence the prolactin levels, the most common ones are the antipsychotic drugs. The other common causes which can lead to hyperprolactinemia are the thyroid disorders, and again, the most common cause of hyperprolactinemia are prolactin secreting tumors, both micro and macroprolactinemia. So another important factor which helps us in the diagnostic evaluation of the causes of hyperprolactinemia is to what level the prolactin level is elevated as compared to the normal range. So when we talk about moderate hyperprolactinemia, we are looking at a level of prolactin level just less than 5 times the normal range. If you go by nanogram per ml, we are looking at about 150. And at this range, many etiologies are possible. And so it is very important to follow a rational diagnostic plan to look into the possible causes of this prolactin elevation. And as I have mentioned, the commonest reason are the drugs, renal and hepatic problems, as this influences the clearance of prolactin from the system. And there are some endocrine disorders which are also associated with increased prolactin levels, which are hypothyroidism and polycystic ovarian syndrome. However, when we look at a very high level of serum prolactin, which is mostly more than 10 times the upper limit of normal, the reason then is pituitary adenomas or pituitary secreting tumors, or some of the non-functioning tumors from the pituitary stalk which prevent the secretion of dopamine secretion reaching the pituitary and releases the inhibitory effect. So this is a sort of flow chart which helps us with coming to the in the diagnostic workup. So if you look at the increased prolactin levels, it's either mild to moderate or marked levels. However, whether it is moderate or marked hyperprolactinemia, the women can have disturbances with in the cycles leading to anovulatory cycles such as oligomenorrhea or amenorrhea. So however, when we are looking at the causes of moderate hyperprolactinemia, the secondary causes become important, and once we look into this and correct them, there is no need to add dopamine agonists to bring down the prolactin level. On the other hand, when we see a marked level, high rise of prolactin, it is very important to arrange a MRI of the pituitary to rule out pituitary tumors. Again, there are two sorts of prolactinomas, either macroprolactinoma, which produces very high levels of prolactin, where therapy is definitely indicated. However, in women with microprolactinemia, which means a tumor is less than 10 millimeter, treatment is not necessarily indicated unless they are symptomatic, which means they have problems with ovulation, they present with irregular menstrual cycles or galactorrhea. It's only in these women treatment is indicated with dopamine agonists. So these are some of the conditions which are associated with hyperprolactinemia. The most common is polycystic ovarian syndrome. Several studies have shown that up to 17% of the women with PCOS do present with mild to moderately raised prolactin levels. However, we have not been able to work out as why this association is existing, and it is however important to remember that no specific treatment towards reducing the prolactin levels is needed. What is needed is a treatment towards PCOS. However, if the level is very highly elevated, there could be a concomitant tumor, and only in those instances further imaging or further diagnostic measures are indicated. Now coming to hypothyroidism, it's again associated with hyperprolactinemia through TRH stimulation, and if treatment with thyroid stimulating hormones is going to bring down the prolactin level, and only when it persists in spite of correction of thyroid hormones or the levels are very high, additional diagnostic tests such as MRI may not be indicated. Now coming to the most commonest cause again, which is pharmacological. As I said, there's a long list of drugs, but the most important is antipsychotics. Both conventional and atypical neuroleptics can increase prolactin levels. And in fact, a significant percentage of women who have increased prolactin levels, of patients on these drugs do have increased prolactin levels. And some of them do have very high levels, even more than 10 times the normal prolactin level. So when patients are on these pharmacological agents which could increase the prolactin level, in order to identify that this is the cause of the problem, we might consider giving a break for a few days to measure again to see the prolactin level is responsible for, if the drug is responsible for the high prolactin. However, it's very important to remember that when we are looking at patients who are on antipsychotics, that such a sort of treatment should be undertaken only in conjunction with the psychiatrist, as stopping the antipsychotics can have disastrous consequences. However, there are certain antipsychotics like some of the atypical neuroleptics which do not increase the serum prolactin levels, and so after discussion with the psychiatrist, it might be possible to move these patients onto that sort of drugs which does not increase the prolactin level. So there, again, after the complete diagnostic evaluation, there's a certain percentage of patients where we do not find any cause. And again, this might be because of very small prolactinomas which we are not able to pick up, and usually we do see that in majority of the patients, the levels do revert back to normal. And this is an important condition which we need to remember, which is macroprolactinemia. Usually the prolactin molecule exists as a monomer. However, in some, the polymers or trimers, which is called big prolactin or big prolactin, these are certain molecules which exist in the blood, which gives rise to high prolactin measurements on the assays, but these do not get attached to the prolactin receptors, which means they do not cause symptoms of hyperprolactinemia. So we do see these patients presenting with moderate hyperprolactinemia, but there are absolutely no symptoms related to hyperprolactinemia. Again, these patients do not need treatment to bring down the levels. However, there are specific tests like gel filtration chromatography or PEG precipitation test which help us identify this condition. So now coming to the MRI imaging, which is mainly done for patients with a very high levels of prolactin. It is mainly to identify prolactin secreting adenomas, microadenomas or macroadenomas. Now, having verified the fact that there is hyperprolactinemia, and secondly, having done the diagnostic evaluation to find out the possible cause of hyperprolactinemia, we need to answer the question, do we need to treat all patients who present with high levels with the dopamine agonists? So it's very important to remember that patients who have symptoms, which is amenorrhea, oligomenorrhea, or anovulatory infertility, these are the patients where we need to initiate treatment to bring down the levels. And the second group of patients who need treatment are those who present with a mass effect. The goals of the treatment in these patients are to normalize the prolactin levels and to get back the gonadal function to normal. So the treatment for hyperprolactinemia can be expectant, and dopamine agonist, the medical therapy, forms the mainstay of treatment for women with hyperprolactinemia, and there is surgery and radiation does play a role in a very small group of patients who present with hyperprolactinemia. So the expectant management would be ideal in women with small prolactinomas and who have regular menstrual cycles. These women can be monitored with serial prolactin level and MRI. As I mentioned, medical therapy forms the mainstay of treatment, and the dopamine agonists which are used are bromocriptine, cabergoline, and quinagoline. Once we use dopamine agonists in women with hyperprolactinemia, as much as 80% of the patients over a period of time do have or develop ovulatory cycles. However, in the rest 20%, in spite of bringing down the prolactin levels to normal, they may not be ovulating, in which case it is important to put them on to either anti-estrogens or gonadotropins to initiate ovulation. So these are the three drugs which are commonly used. The advantages with bromocriptine is that it has been in use for a long time and its safety has been well established in pregnancy. So this is the drug of choice when women who are on dopamine agonists get pregnant. However, the major side effect with bromocriptine is the side effects can be quite intolerant to patients, and about 10% of them find this quite intolerant and not able to continue with the medication. And the multiple dosing, which reduces the patient compliance. When we move to cabergoline, it is used on a once or a twice weekly basis, and it is the side effects are far less compared to bromocriptine, making it the drug of choice in women with hyperprolactinemia. And the third thing is the quinaglide, which has got a half-life of 24 hours, which means that we can use it on a once daily basis. Again, it has got good efficacy and good tolerability. So the patients could be put on cabergoline and quinaglide, and once they get pregnant, we can, with microprolactinomas, the treatment can be stopped, and if needed, bromocriptine can be initiated during pregnancy. And in macroprolactinomas, obviously, we have to consider other issues as well. So regarding the role of surgery, there is a limited role of surgery, and this is mainly in women who are unresponsive or intolerant to medical therapy. However, this mainly applied to the age where we were using bromocriptine, and with cabergoline and quinaglide, the response is quite good to medical therapy. But there is a role definitely for surgery in women who present with large non-functional tumors and patients on neuroleptic medication for whom dopamine agonist may not be appropriate, and women with macroadenomas who wish to get pregnant. This is important mainly because macroadenoma can increase up to 25% in its size during pregnancy, and it is important to have a control over the condition before the woman gets pregnant. Again, radiation has got a very selected use when pharmacotherapy and surgery fail, and the main side effect being hypopituitarism. So to summarize what we have seen so far, it is important to confirm the diagnosis of hyperprolactinemia and to do a diagnostic evaluation to find out the possible causes of hyperprolactinemia so that the treatment is directed towards that. Treatment is needed only if the woman presents with menstrual disorders or anovulatory infertility, and dopamine agonists remain the mainstay of treatment and is quite safe to use in pregnancy. So hyperprolactinemia is a common disorder, and microprolactinomas are quite frequent finding in young women, and dopamine agonists restore normal ovarian function and are the preferred treatments for most patients wishing to achieve a pregnancy. Thank you.